Vanakkam Chennai. I am Dr. Dutta. I am an endocrinologist based in Dwarka, New Delhi. It's a matter of big pride to be part of the Golden Jubilee celebrations of RSSDI Annual Conference 2022. And here I have presented the data, the review of clinical trials on GLP-1 analogs, the unsung heroes in the management of diabetes. But more importantly, this is a class of drug which has great data in terms of causing weight loss. It's a great data in terms of causing diabetes remission. It has a great data in fatty liver disease, in PCOS also. So I am going to share the evidence, the literature from different clinical trials. We as a group, we published the first meta-analysis evaluating the role of GLP-1 analogs in metabolism associated fatty liver disease, which is better known as non-alcoholic fatty liver disease. We published in diabetes research and clinical reviews. We showed that when we use injectable semaglutide, we reviewed data from 4 different trials which had around 2,100 odd patients, and primary outcome was improvement in NFLD parameters. We demonstrated that when we use half the dose recommended in people with diabetes, that's only 0.4 to 0.5 milligrams of injectable semaglutide once a week instead of 1 milligram weekly, which is recommended in type 2 diabetes, that half the maximal dose. It is a great agent in reducing liver enzymes, the SGPT. The liver stiffness score, the fibroscan score comes down by nearly 4 kilopascals, and there is a single trial showing a beneficial impact in liver histopathology. Obviously, one trial is too less, so we need more data in larger number of trials to show document histopathological improvement in NFLD, but till then we have good data in reduction of SGPT and liver stiffness scores, and this data comes from trials with a good follow-up of nearly 2 to 3 years of follow-up. Of course, we all have heard about the use of GLP-1 analogs in type 2 diabetes. Here I am going to highlight in the non-diabetes scenarios. The next important scenario is polycystic ovary syndrome. We know that 1 in 3 women in India have PCOS. With the increased prevalence of childhood obesity and metabolic syndrome, PCOS goes up. These women not only have the issues of cosmetic problems like facial hair, acne, they have issues with fertility. Infertility is a major problem. They have issues with their lipid parameters, and ultimately they have a higher risk of type 2 diabetes. Data on use of GLP-1 analogs in PCOS is largely short-term data of 12 to 26 weeks data, and data has primarily been studied with 3 molecules, which is liraglutide and exenatide, and there is a single small trial on the use of injectable semaglutide. So yes, we need stronger data. We have nearly 15 to 20 different trials from across the globe where they have used GLP-1 analogs either alone or with metformin to cause weight loss. Yes, in PCOS without diabetes, this causes a good weight loss, but the challenge, the practical challenge is that once we cause weight loss in PCOS, the fertility improves and this patient would conceive. And we know that GLP-1 analogs are not safe in pregnancy, they are not recommended in pregnancy. So the key point, if we are using a GLP-1 analog for short periods of time in PCOS, use an appropriate contraception. And once you stop the medicine, a good washout of 4 to 6 weeks is recommended before the lady actually conceives. That's an important point which has to be kept in mind. Now, bone health and GLP-1 analogs, nobody discusses. A lot of basic science and translational research shows that GLP-1 agonism has a good beneficial impact on osteoblastic activity, that it promotes bone formation in animal models. But does it make a difference in real life? So we have data from nearly 6 to 8 different clinical trials where they've evaluated the bone turnover markers and bone mineral density nearly around 52 to 106 weeks of clinical use. But this is one area, although the basic science data suggests an improvement in bone density, the clinical data, the human trial data showed that there is no significant improvement in bone density scores. The fracture risk did not come down significantly over 2 to 3 years of use of GLP-1 analogs. So there is a difference between what we actually got in real world scenario and what was seen in the basic science. But still a good take home message is these are bone neutral agents as compared to SGLT2 inhibitors, which are shown to cause osteoporosis. They are known to promote bone mineral loss. We also know that glitazones as a class of anti-diabetic agents also cause bone mineral loss. So GLP-1 analogs can be safely used in people with osteoporosis. That's the key take home message. Kidney disease and GLP-1 analogs, again very less discussed. I think we must realize 1 in 10 global population have some degree of kidney disease. That number goes up to 30% in people living with diabetes. a key take home message from all the different clinical trials is that GLP-1 analogs are safe to be used in patients with mild, moderate and severe CKD. We do not need any dose adjustment with any of the GLP-1 analogs. The key point is advanced kidney disease is linked with cachexia, anorexia, GI problems. When you add GLP-1 analogs in advanced kidney disease, it may worsen the GI side effects. That's a practical problem which you might face, but mechanistically they can be used in across the spectrum of kidney disease. Regarding renal benefits, I think F-peglinetide, the latest GLP-1 analog, 6 mg once a week, the Amplitude O study showed that it has a significant nearly 35% reduction in urine protein loss. Apart from it, we have strong data for liraglutide and dulaglutide and semaglutide showing a beneficial impact in improving holistic renal outcome. That is, the composite renal outcomes are significantly improved with these agents. By composite renal outcomes, we are talking of it reduces the decrease in GFR by more than 40%, it reduces the risk for progression to end-stage kidney disease, it reduces the risk of renal death. So yes, they are renal safe and they have a renoprotective effect primarily in people with overt proteinuria. The renal benefits of GLP-1 analogs are blunted in people without overt proteinuria. CVOTs, I think we all know, I am not highlighting. They are great cardio-safe agents and they improve cardiovascular outcome. The data is strongest with liraglutide, dulaglutide and semaglutide, the injectable semaglutide in terms of improving 3 or 4 point MACE. The oral semaglutide has not shown to reduce the 3, 2 and 4 point MACE significantly. Again, when we move on to heart failure, all the GLP-1 analogs are heart failure neutral. They can be used in people with heart failure safely, but they don't improve the heart failure outcomes. Like SGLT2 inhibitors, the only exception is F-peglinetide. In the Amplitude O study, it showed a 39% reduction in hospital admission in people with existing heart failure. So yes, to summarize, GLP-1 analogs are great agents, great CV safe agents. Now we have F-peglinetide, which is improves outcomes in heart failure patients also. They are great weight loss medications in people with obesity without diabetes. Very encouraging data coming in people with fatty liver disease and PCOS. Thank you.